Good afternoon. Welcome to Caraconference 2024. We are so pleased to have you with us here today. My name is Linda Sider, and I have had the honor and privilege to serve as Caracol's CEO for the past 20 years. On October 4th, I'm retiring. The theme of the conference really resonates with me this year. In the early 90s, I was the CEO of a different AIDS service organization here in town. At that time, HIV was essentially a death sentence. We tragically watched while so many young people died of a disease riddled with shame and stigma. It was a dark, terrible time. Fast forward to today, 2024. While the medications have undoubtedly saved lives and allowed those living with HIV the ability to live long, full lives, it's been wonderful and amazing and transformative. Those changes are monumental and were unimaginable 30 years ago. So here we are. Yet, with all the medical advances at our fingertips, if we don't have access to the drugs, to the medical care, it matters not. This is where we all come in, and the theme of this conference and our fight for equitable access for care and treatment. While the science has come so far, it's up to us to ensure that everyone, and I mean everyone, has the opportunity to live a full, healthy life with HIV. Thank you all for the work you do. It's made a huge difference, and we've come so far. But as we know, we have so much further to go. I hope you enjoy this conference, and I want to introduce you to Adam Riley. Adam is our prevention manager here at Caracol, and he's the coordinator for this conference. So all that you have to learn this week and all that you experience, you can thank Adam for that. Adam?
Thanks, Linda. Can you hear me? My camera is not working properly at the moment. There we go. All right. Welcome, everybody. I am just going to go through a couple of housekeeping slides here. So again, welcome to Caraconference 2024, Advocacy in Action, HIV Policy as Healthcare. We are Caracol, Greater Cincinnati's HIV nonprofit devoted to positively changing lives in the fight against HIV through prevention, housing, and care. You can learn more at caracol.org. For the webinar today, how to use Zoom. If you have any general questions and you want to chat with other attendees, please put those in the chat. Or if you have any technical issues, put those in the chat as well. But if you have questions for our presenter, please put those in the Q&A. We have people in the background monitoring that. I'd like to give a special thanks to our presenting partner, Maytech, the Midwest AIDS Training and Education Center at the University of Cincinnati. Thanks for all your help and support on this conference. We do have evaluations and credits for each session this week, so we are providing continuing education credits. This link for today's webinar, the evaluation link will pop up as you exit. It will also be placed in the chat. If you aren't able to get it through the pop-up or through the chat, you can email me, and my email will be in the chat. We do ask that you fill those out, complete those today by the end of the business day so that we can meet all the requirements for the board to give these education credits. And today, I'd like to welcome our opening speaker who's going to talk about the HIV Stigma Index, connecting the dots. Our presenter today is Katrina Balovlix. I totally butchered her name, and I'm sorry for that, Katrina. But I will go ahead and stop sharing my screen and pass it over to you. Thank you so much for being with us today.
All right. Thank you guys, everyone, so much for having me and the kind introductions. So I am going to go ahead and put up our slides. I'm going to do the first couple slides, and then we're actually going to do a little interactive brainstorming activity through Mentimeter. I don't know if anyone has used that, but it'll use a QR code through the slides. And then once everybody scanned the QR code and started entering things, then I'll take you to the visual where everything pops up. So let me go ahead and set up our slides so that we're ready to go. All right, so as you all know, this is where we are and the work that we are doing today. I do not have any disclosures to report. You all know the title. So we're looking at measuring and challenging HIV-related stigma through the HIV Stigma Index. And this is our group discussion. So if those of you, you can either use the link and then to enter the code, or you can use your telephone to scan the QR code. And I'll leave this up for a few seconds, and then we'll go ahead and we will look at the results that pop up. So you should have come up with something that looks like this. I guess if I can get a thumbs up to know that everybody saw it or sees it.
I think it's working.
We think it's working. Okay, that sounds great. All right, experience with sex ed, very clinical. Okay, that's interesting. Didn't have any, pretty common. Abstinence based. All right, I'm seeing a lot of themes here. Okay, so people either received it as workplace education, using a banana, okay, abstinence only. Are you guys seeing what I'm seeing, just to be sure? Adam, Zoe, can everyone see what I'm seeing with the Mentimeter?
Katrina, we were currently seeing your slides instead of the Mentimeter.
Okay, that's what I was worried about. So let me go ahead and change that. All right, now does everybody see it?
There
I
we
think
go.
we've got it now.
Okay, so it looks like we have a variety of responses from things that were clinical, some sex ed courses, not a lot, sex was for marriage only, abstinence only, education. Okay, that makes a lot of sense. And we ask that because so much of what we talk about with stigma and sex education starts from a very early age. So the lessons that we got or didn't get growing up about what sex looked like, what normative sex was, and how we viewed STIs. So going from there, we'll go back to our presentation for now. And people can put into, let me stop share and go back to our other slide deck. And for this one, I'm sorry, the text at the bottom keeps cutting off where the buttons are that I need. Okay. All right, so we're back. All right, and also thinking for people if they just want to put some things in the Q&A from here or, you know, mention things in the chat, what are some early images do you recall from mainstream social media outlets about HIV? So it looks like we open that to a question?
We've got people responding in the chat.
People responding in the chat perfectly. Die-ins, people, a gay man's disease. Yeah, contagious or untouchable. People, I remember Princess Diana, the picture of her visiting children with HIV, remembering the story of Ryan White, all of this kind of stuff, right? So what we don't see here is a lot of positive images that people are describing. So this is really the most significant thing. And when we think about it is we didn't learn a lot, said, and then we also didn't learn a lot from our community. So what this resulted in is higher levels of stigma, not surprisingly. So I want to make sure that we're all using the same definitions here when we talk about things. So we're going to look at stigma, breaking it down into both internalized stigma, or those views that we hold about ourselves when we absorb assumptions and stereotypes from the dominant culture, which in this term, the dominant culture would be people without living with HIV. And those who external stigma being that those are the preconceived notions that come at us. And with that, we're also talking about things like labeling, separation, status loss, discrimination, which we're going to define right below, and thinking about how this creates power dynamics and hierarchies in society. So when we talk about discrimination, we're really talking about two things here. We're talking about this practice of othering, which is why we treat individuals and groups differently, and something that people living with HIV, actually like myself, not only have I been doing this work for over 20 years, I've been living with HIV for almost 13 now, is this idea that we've had to navigate stigma since the earliest days of the pandemic. So when first started as othering, actually became a issue of legal discrimination or enacted stigma. And with that, gives people with civil rights law protections to keep people from being treated in an unequal or unfair manner, or some way to, at least for there to be consequences and repercussions for those kind of actions. And so HIV/AIDS is protected under the umbrella of disabilities under the American Disabilities Act. And there's actually a lot of questions, should it remain classified as a disability, knowing that while our functional limitations have changed and our lifestyles are different and we can live normal food lives, do we still need that classification of the disability because of all the other things that go along with it? And one thing when we think about HIV-related stigma, that we actually find it to be a pretty universal experience. Some sort of stigmatizing conditions or stigmatizing events categorize people differently. But for us, we find that people living with HIV have a very similar experience when it comes to what stigma looks like. So we try to address this in two ways. We look at person-first language and identity-first language. So person-first language means we put the person before the condition. So using a common one for mental health that I just picked is versus with a person with schizophrenia versus a schizophrenic. Identity-first language forms the disability by highlighting that first. Now, it's one of those areas where some communities prefer person-first language, and some communities, particularly the deaf community, like identity-first language. I always feel like identity-first language is something you are invited to do, and person-first language is a way we start. So beginning the conversation by putting the person before the condition, and I've seen, a change over the years. People with HIV/AIDS, people with HIV. Now I'm seeing more people with life experience, right? But being invited into that conversation if we're going to talk about something differently. So I've attached here is a screenshot from the National Institute and Allergy of Infectious Disease, their newest language guide for HIV, and the publication number is down there. I highly recommend it. This is just a sample where it takes stigmatizing terms or outdated terms and recommends alternatives for these terms. So here we're talking about sort of how we talk about infection, right? So, and particularly research, right? Whether someone is a subject versus a volunteer. Talking about HIV when we mean HIV and not AIDS, right? Instead of mother to child, perinatal. So when we're looking at that, are lifetime survivors. Our lifetime survivors also in the community like to be called dandelions, which is really cool. I'm not sure if anyone knew that. And then thinking about, especially I like this one at the bottom with hard to reach populations, I like to consider that hardly reached populations, right? Because while we may not be getting to them, hard to reach puts a lot of onus on the individual being reached. Hardly reach creates a community in which we both get to think about what reaching each other means in a more collaborative approach. So when we talk about things, when we're talking about stigma, we're talking in twofold. We're talking about medical language, and we're also talking about public health language. So medical language being the interventions we have when we're one-on-one, and that public health language being more for what we use for the larger landscape. So when we think about difference between individual healthcare, what I refer to in micro practice under my social work lens, and population health being a macro practice, we're looking at clinically tailored interventions versus clinical guidelines. If I can think of an example for that, clinical guideline says that doxypep is not as highly effective for women as it is for the MSM community. So while a clinically tailored intervention might find someone and say, oh, this may actually be a good benefit for you, as a harm reduction approach under clinical guidelines, it may not be the number one most recommended thing. Similarly, when we think about the difference between individual level messaging and population health community educations. We're talking about those conversations that we have one-on-one with people versus when we're talking about reported indicators and measures. And I like to use the example of the word risk here and thinking about how the conversation has changed over the years. So one of the things when we're talking about risk is moving to the idea that people and communities are not inherently risky or high risk, right? So these terms acknowledge social challenges and recognize stigmatizing disease dynamics, right? So what we might want to say is affected community, high incidence population, those who are disproportionately affected. And the other thing where we see where this communicated with risk is the language we use around U equals U, and making sure that we're using a simple message that undetectable equals untransmittable. Then sometimes you see these qualifying messages that confuse people, right? Almost no risk greatly reduces close to zero. Where we use these modifiers, then we get away from the answers and what people are really looking for in the message, right? So when we think about risk, it means different things at an individual level than it does at a public health level. Legends, I'm just looking at the comments. Yes. I like to say legends. I also like to say for our patients, clients, consumers, volunteers, I like to call us subject matter experts, actually, because as a subject matter expert, right, the research is done on our thoughts and our bodies. And when you really want the answer to something of what working and what isn't working, right, you come to the community of those who are most involved in the day-to-day work. So I also like to refer to us as subject matter experts of our bodies and subject matter experts of our field. So another term that we've moved away from is we originally started with this term of medication compliance, right? And compliance really had a negative connotation to it. And we've since moved to adherence. And I am positing that we move towards medication maintenance. Compliance and adherence both create a hierarchy in which somebody has to do something that they are supposed to do, or if they're not, they are doing something negatively in poor judgment, in this case, not good for their health. Where if we approach something from medication maintenance, we're really looking at something as the collaborative care approach. And that's something that our community has really started pushing. I don't know that we've been picked up totally into the mainstream yet, or I definitely know we're not HRSA HAB language yet. But thinking about it when you're interacting individually with people, to what would it be to change that conversation from are you adhering to your medication to are you having any challenges maintaining your medication regimen? And sort of flipping that conversation to decrease the challenges and power dynamics and those differences to really be patient-centered and collaborative within the entire healthcare team. So some of the things that we see when it comes to responses to stigmatization is we talk about people trying to physically remove the stigma. So people, if they feel stigmatized about glasses, might get contacts, mastering the area that stigmatizes them, right? Knowing everything that they need to know and possible ways to respond to different situations. Using their stigma as secondary gain. Is there something that there is a way to get something out of this? This one always makes me feel a little on the inside, but I'm not going to argue with Goffman and his research. I have definitely seen people who view their stigma as a blessing. And then when it comes to this idea of normals, and Goffman did his work early in the day, so it was normals were the people who were not experiencing the stigma. We wouldn't use that term anymore. But that was what he used in his term of research. And then think about how we switch out and look for people who are sympathetic to us. Oh, thank you, Carla. I appreciate that. So have you guys seen, and you can use the chat here as well, about some of these responses to stigmatization? Have you seen them in your interactions with your clients, patients, subject matter experts? I'm curious to see, where have you seen any of this work out? in your clinical spaces. And yes, people are definitely also having conversations about what viral suppression means and stigma around viral suppression. Okay, using yours as a tool. Mastery and avoiding? Yeah, absolutely. Avoiding. That's powerful. Viral suppression is power. Embracing their stigma. Okay. So rather than embracing their diagnosis, okay, I like the wording there. All right. Awesome, folks. Thank you guys so much for participating. So I don't know if anybody's seen this. It makes me think of a battery or a closed circuit. But when we're talking about is we're talking about the impact of HIV related stigma within our structures, which includes the structures of care that we all practice in, as well as intersectional stigmas, which are those plus ones that go with the primary stigma. So we may be talking about, HIV and race, HIV and class, HIV and gender, HIV and sexuality, HIV and ability. And from those stigmas that we get from our structures of care and the added layer of the intersexual stigmas that people bring into us, then they've experienced that HIV related stigma. And when we're talking about enacted stigma, right, is that individual experience of someone being discriminated against. We look at community level stigma of how we're perceived within the larger community and what that means. There's also this idea of anticipated stigma, right? And that's the idea that even before something stigmatized happens to us, we're waiting for that other shoe to drop. Or maybe we avoid something because we anticipate stigmatizing interactions with others. And then already talked about this a little bit, is when we take all of that nasty messaging from others and it becomes part of our identity and part of who we are and how we view ourselves. And what we know with internalized stigma and all of these experiences of stigma, the result is that there are challenges in retention and care. We see people not maintaining their medications. And on the outcomes, we see changes in CD4 counts and viral loads, right? Now, I left these mechanisms out in the middle because these are some of our protective factors. And whether these mechanisms are in place to protect us or whether we're lacking those can make a huge difference in the HIV-related outcomes and engagement in care. So when we're talking about interpersonal factors, we're talking about our social structures. Do we have people who care about us? Do we have someone to call on a bad day? Have we disclosed our status to someone that we can trust? Sometimes we may be the only people who actually know what's going on in someone's life in regard to their HIV. Psychological resources. Psychological resource can sort of be that internal mechanism of where we view our locus of control, our mental health, and also having access to psychological resources to support us. And we know there is a shortage of mental health providers around the country, so sometimes there is limited access to those. But that's something, having a psychological resource to help you build your wherewithal is a positive predictor for engagement and care, right? We're talking about mental health. That sort of becomes this combination of interpersonal psychological resources. And then at the end, we have our stress processes. And as people, we sort of, and this is with any chronic condition, we sort of move within these things, and the stress processes being external stressors or health-related stressors. So when we're looking at the outcome, we know that the best way to improve engagement in care, the best way to keep people to take their medication, the best way to help people get to an undetectable viral load and to maintain that CD4 count over 200, right, is this idea of removing stigma, because stigma creates barriers to care. So where we see this at a practical level before we get into the index is we see people that are averse to getting tested. Testing bans are a mixed bag. Sometimes people feel really comfortable doing testing. Some people feel challenged in that sort of experience and don't want to be seen going in and out of a testing ban. I always say it's helpful. It's always good to offer a +1 service with your testing if you can, so that there is maybe more than one reason that someone would come on your van if you do community outreach. right? There may be a fear of going into clinical or community-based entities, things that have, HIV or AIDS in the name. Sometimes we like to couch that in the term of positive something or other, which in this day and age isn't really fooling anybody. And thinking about what it means to have spaces with neutral connotations, neutral names, and not going to that one clinic every Thursday because someone knows that that's where all the people with HIV go. And then this becomes the problem, especially when we think about rural health and what that means for people who may not have other options and may know fewer people with HIV and may have less access to community resource because of where they are. People who are experiencing stigma and discrimination often socially isolate from others. We talked a little bit of how it can affect mental health systems. And stigma creates medical mistrust because if we're not able to communicate openly with, as two humans in the same level in the same space, it becomes easier to doubt what happens. And we're not even talking about medical mistrust when you're in the exam room. We're talking about the experience that that person has the minute they walk in and see your front desk staff and are registered and checked in, what their experience is with the medical assistant or the nurse, even before they get to the provider doing that care. One of the areas where we work well with addressing medical mistrust is the use of peers or patient liaisons or community health workers, and how that can help minimize those by partnering with someone who is with experiencing stigma, with someone who's a little bit of an older head, who has a little bit more knowledge, who has a little bit more wherewithal, who can provide someone support to try to get over some of those humps. So measuring stigma is hard. Right. We don't have a uniform measure here in the US. We have our 90-90-90, right? To get 90% of people diagnosed, 90% of people on treatment, 90% of people virally suppressed. The global World Health Organization goals have moved to 95-95-95. So setting the bar a little bit higher, right? When we're looking at work and measuring stigma, the question of resources and institutional and jurisdictional buy-in comes in. How much effort are people willing to put into this? And by effort, I mean, this takes time, resources, this takes human capital and things like that when we're looking at it. Stigma is a subjective measure. So while we have the definition I use, there are other acceptable definitions of stigma and HIV-related stigma. And it's one of those things that's hard because we don't know it until we experience it. We do know that all of the respective approaches that are out there come out to find similar findings. So if you look at the HIV Stigma Index, the CDC Medical Monitoring Project, the GLAAD State of HIV Stigma Report for 2023, you're going to see a lot of the same outcomes. So we're all pretty close. What we're looking at with the Stigma Index is one way that we can get everybody on the same page to create a more universal measure. So what do we know about the Stigma Index? So even though we call it a index, what it really is a survey with about 100 questions addressing different types of stigma, related phenomenon, and using these research and data collection for dissemination. So we're talking about an index here that's actually a study. So it is conducted by people living with HIV, for people living with HIV, and using this same almost patient care liaison model to use openness and build confidence so that we can share our experiences with people who are like us. So sometimes when we're with an interviewer who is not part of our community, we may be fearful of what to say because we don't want to hurt someone else's feelings, or we may fear repercussions. However, by doing this with someone else from our community, it helps remove some of that. It is a standardized tool. So there's not a lot of variety in it. Everybody is doing it the same way. And as I mentioned, we use it for data collection and advocacy. So we got some funny names up here. So for one, it was developed by the Global Network of People Living with HIVs, the GNP+, the International Community of Women Living with HIVs, the ICW, UNAIDS, and the International Planned Parenthood Federation. So, and this first came about in 2008. Since then, it's been completed in over 100 countries with over 100,000 interviewees, making it the largest stigma study of its kind. And it supports the principle of greater involvement of people with HIV, which we sometimes hear more common here in the US as meaningful involvement by people living with HIV. So GIPA and MIPA are the same principle, just two different words. So what do we know about it? So we had about 10 years of experience doing the survey. And then in 2017, people decided that we were going to go back in and update it. So they added new domains. We looked at an expanded healthcare access session, and we came up with a new questionnaire that was streamlined and easier to use. So some of the changes include a 2-part gender identity question that was lacking in the first survey, a new survey containing validated measures for stigma items, a refined set of reproductive health questions as part of that expanded health access, validated scales to assess anxiety, depression, and internalized stigma, and also a new people living with HIV resilience scale. So all of those changes were made in 2018. And then in 2020, a standard methodology for implementation was added in. So what do we know about this index? It is validated. It was an iterative process driven by people with HIV, revised, pre-tested, formally evaluated in 3 cross-sectional studies, primarily in Cameroon, Senegal, and Uganda. It included snowball sampling, regular surveying, focus groups, and cognitive interviews. And if anyone wants a little bit more information on it, here are some other resources that people can look at. You can pull these from the slides. I'm sure most of them can get these through your institutions. If you have any trouble accessing them, let your presenters know, and I'm happy to share these articles in the back end if anybody needs them. But I know as providers, we also like our science. So the principles of our survey include capacity building, accountability and ownership, embracing equality and diversity, and to be advocacy oriented. By that, we mean capacity building, that we are building the capacity of people administering the survey, building the capacity of the people receiving the survey, working in collaboration with partners in the country, and technical assistance from the international partnership. And at the end, we're going to talk a little bit about how to get this started. Right? Accountability and ownership. We talked about GIPA or MIPA, right? And what it means for people to decide to do this within their own country and centering people centering people with HIV within the process. Knowing that various networks can take the lead, but that this should be not only an iterative process, but a collaborative process, so that we're embracing diversity, embracing gender equality, and making sure that we do not isolate individuals who we identify as key populations or highly impacted populations. And through the advocacy orientation through this, the data from the Stigma Index is actually used to address discriminatory statutes and policies. So these things are actually being used to change laws. So moving right ahead, you can see who is doing the work where on the stigma study. So as we can see, it has not been fully implemented here in the United States, but it has made its way, completed in many parts around the country and in the part around the world. And for other places, there are a lot of places who are actively going through the process. So especially since 2018, we have seen this grow and change. So how do we study stigma? How would we implement the Stigma Index? Right. So what we're looking at is, I don't know how many folks, if you're familiar with implementation science, but we call this the active implementation framework. And I'm going to talk through it just a little bit and see that each of these are structural components to make up for an effective intervention. So what we want to do is use the strengths of the community in each of these arms. And we start with leadership as the foundation and forming the base of our triangle, right? And leadership may take the form of technical training or adaptive people leadership. Our organizational drivers here on the right we're talking about things that are the support and infrastructure needed to create an environment for the program. And not even just create an environment, but let's say create a welcoming environment or a supportive environment or a hospitable environment, right? Where people feel welcome to this process. Our competency drivers are the activities we use to develop, improve, and sustain practices, and to support staff to be able to put programs and innovation into practice, right? So training, selection are the people that we pick to do the process, training to make sure that there is baseline competency, and continuing to coach and re-educate as needed. And then while we look at that, when we think about things that are compensatory and integrated, integrated means that our philosophies, goals, knowledge, and skills are consistent and thoughtfully expressed within the arms. And compensatory means that the skills and abilities not acquired or supported through one driver can be compensated through another driver. So looking at it like that through the different arms. Okay. Before I move on, do we have any questions that we can put in the chat? Do people understand this? I know this is it's a little bit of a wonky diagram. So is everybody feeling good about it? Thumbs up, thumbs down, questions, comments? All right. I don't see anything coming up, so I'm gonna, all right, Angela, thank you for the thumbs up. All right, great, thank you. All right, so where do we go next? We're gonna actually look at some of these drivers and thinking about when you're doing it. These are the questions that we need to ask of people to make it fun, effective, and supportive. And we really do need to make this fun. We need people to buy in. So if we look actually starting with our questions at the bottom and our leadership drivers, who are the champions in this project? If this is something you even want to do at an institutional level or jurisdictional level, maybe a couple of counties want to do this, right? Maybe the state wants to take this on. Maybe a couple CBOs that collaborate with each other want to try this, right? Who are the people who are going to be the most excited people in this project to get them done? And you can probably think of them in your head because they probably already get excited about other initiatives. They might be the person who always has their hand up in the meeting. They may even be like that, ooh, 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 ooh kind of person. I'm one of those people. Sometimes we're fun. I know sometimes we can be a little bit over the top, but I promise you we make great project champions, right? How do we center this and lead with the community? And how do we make sure we're getting community buy-in from people who are living with HIV, right? And acknowledging that we're asking people to become champions of a project that's addressing stigma without triggering or activating or harming people doing the work, right? So building up from there to our competency drivers, we'll go to organizational in the middle, right? To make people feel empowered and safe and not activated, we need to think about the resources and trainings that need to get done. How many people do we think we need to do the work? If we underestimate, we're going to get frustrated and get stuck. It's better to assign too many people to a project and tell them, thank you for your time and effort. I think we have it from now, than to be 3 or 4 months in and then notice we have a huge gap and have to catch somebody else up. So think big picture when you're doing this and think long term, because this isn't a 1 week, 2 week PDSA cycle, right? This is something that's going to be substantive and formative. And so when we're thinking about that in that long role, thinking about our strengths and tools, anticipating obstacles, defining our goal, having an aim statement and SMART goals, right? Our specific, measurable, achievable, relative, and time specific. And then how we're going to be keeping our data for security, for confidentiality, so it can be anonymized into results, knowing that some people will have access to electronic resources and there may be a small subset of people who you need to do the survey with on paper. Best practice and how this has been recommended and done within the Stigma Index survey is for people to do it on their phones, laptops, sharing tablets, bringing them out into the community or within the center to decrease a reliance on paper. So the nitty gritty, implementing the PLWH HIV Stigma Index. It's really simple. When you go to their website, there's a tab that says Start Your Journey with Us. And the stigmaindex.org right there about the Stigma Index, if you go to that link at the bottom, this is where you'll come. So from there, we're calling it Ready, Set, Go. There is an intake form that must be completed and submitted to the international partnership to talk about your interest and intent to implement the HIV Stigma Index survey, right? So they describe it as a continuous and systematic journey of activism. And so they'll actually help get you started. So they walk you through this preparation, they walk you through the planning, they'll walk you for data collection, they will support your data analysis and your reporting, and they will help you with advocacy tools as you go along. So when we think about after we've done it, we're thinking about, okay, we're going to implement this great thing. We're going to have the support of the organization. We're going to get amazing results. And I know all of you will. And then we're going to think about, and just putting this out there, even though the process hasn't started yet, to think about maintenance, because we should think about maintaining a project and maintaining our results from the very first step, right? As part of our aim statement and our goals, what are we hoping to achieve and how do we maintain that change, right? And knowing that maintenance is not a static process, right? Our findings, as they change and will continue to change, need to be responsive to shaping policies, program, and processes within our own respective environment, as well as advocating on a larger stage. And that may be things sort of thinking along the lines of Prep for All campaigns, reauthorization of the Ryan White Care and Treatment Act, PEPFAR funding. So thinking about what it means to do on that larger scale stage as well. Interventions must include the community. If you've come up with an intervention that wasn't centered around the community and that the community did not help create, you're going to be limiting the effectiveness of your intervention because you didn't create buy-in before you started it. So we're really talking about removing silos, taking off lab coats, taking off name badges, taking off titles, and really just interacting human to human for a shared cause. And any documents that we create, we call them living and breathing because we're rapidly responding to changes in the epidemic. And as were mentioned before, the changes in the last 30 plus years of the epidemic and how it's going to impact those who are most vulnerable. So I don't know, does anybody know what these two states are? I put up the pictures to see as like a pop quiz. Oh, I just cheated. Now you're going to miss it because I hit the wrong thing. I was going to go to the chat. Okay, Michigan and Louisiana. Everybody is great. Okay, you guys got it. I am impressed. All right, Geography 101 on point. All of your middle school geography teachers should be very proud of you.
Katrina,
All right. Yes.
hey, sorry to interrupt. I got two questions.
Please.
Kat had a question about, has the stigma index ever been used at a county level that you know of?
I do not know whether it has been done. Well, that's not true. So it has been done jurisdictionally. So it's been done in Louisiana and Baton Rouge and New Orleans. So it can be done at whatever size you want. And so Baton Rouge and New Orleans are Louisiana's Part A programs. So yes, it can be done on whatever level you're interested in.
Thank you. And then we have one other question in the Q&A that says, does the study look at the root causes of stigma? If yes, does the outcome provide space to address these root causes?
That is an excellent question. So I'm going to go with, it talks about people's experiences, and based on the evidence developed or the evidence identified when you're administering the survey, then when you're doing the data analysis, you can look at some of those root causes. And, you know, because so much of this is used for advocacy, that's why those root causes are then translated into policy action. So yes, when you're doing it, you may see and identify some of those root causes. And because of that, you get to individualize the space and the intervention for your community. Does that answer the question?
I think so. Yes, the person that asked that question put in the chat that it does.
Okay, wonderful. All right, so 2 living, breathing examples for you. So the Stigma Index being led by the Positive Women's Network USA branch has been doing the Stigma Index 2.0. They actually did the original Stigma Index in 2017 before the updated version was released. And we're just going to look at some of their data real quick. So when we looked at Baton Rouge and we had this question of stigma, and their results are also available. So if someone would like to see the presentation from Louisiana, I am also happy to make that available. This is publicly available through LSU. So healthcare workers discriminated against participants in the last 12 months. We see a lot of areas here with over 13%, right? So we're talking about dentists, we're talking about emergency room staff, we're talking about OBGYNs, we're talking about general healthcare providers, and even infectious disease nurses and providers, right? So what we're really seeing is within this system of care, people are experiencing a lot of stigma and discrimination. And what we can do by seeing where we're finding this happening is to target interventions, right? Are there gynecological providers who lack knowledge? If we're seeing this with doctors and nurses, do we need to be doing different types of continuing education? Do we need to be changing medical school education? Do we need to be requiring different CEUs? Do we need person-to-person level interventions in our settings? Right? So seeing kind of what we're experiencing here and how we may want to tailor if we get these results for our community. Like I said, whatever scale that you're doing that at. And then we move here from stigma to actual discrimination. And once again, we see this really big in OBGYN. I can say I have also had extremely personalized stigmatizing experiences then. So even looking at this, I would say as a single PLWA or PLWH or PLPWLE, whatever I am now based on the current jargon, that this tracks for me, actually. I've seen a lot of stigma and discrimination at dental offices and GYN offices. And I think it's because they don't receive a lot of specific training around us. And there's a lot of outdated information. And maybe they received a class or haven't received a class since some of those early days of what they saw on the media and what they got in high school on sexual health education, if they got any. Right. So kind of trying to bring some of that early education and what people learn and how this results later in practice. And sometimes we have this thing called implicit bias where we don't even know we're doing it, but we all carry our biases. And if we don't address our own implicit biases, and we don't really know that we have them until they're challenged and they give us this kind of icky feeling inside, and figuring it out what it is about us that we need to change rather than letting that sort of icky feeling, and that's my therapist talk here about icky, right? So I have a combination of public health work and therapist work, and so icky, we're going to call it clinical term here, and thinking about what we need to do to address that within ourselves rather than being defensive or dismissive. When we go into Michigan, their data looks a little bit different, but engagement and social avoidance behaviors was one thing here. And we can see that lots of people isolate. We're talking about here over half the people interviewed in Michigan reporting isolating. Almost half reported avoiding disclosure. Still, we're talking about almost half and looking at not attending gatherings, not deciding to have sex, and even people moving, although it's less than 10% here, people feeling like they can't get married, right? So what does it mean to really limit yourself in this engagement because of stigma and discrimination? Similarly, we talked about people having here this internalized stigma, and, lots of people, almost 50% of people here, or no, this is 20, 40, 60, 80, sorry, almost 80% of people reporting that they blame themselves for something that happened to them, feeling a lot of guilt and shame, affecting their self-esteem. And then we see other behaviors like anger, wanting to externalize that blame on someone else, even if there isn't someone to blame, and even causing things like suicidal ideation and people feeling that they should be punished for having HIV, and what it means for people to be bathed in care, knowing they feel all of this stuff inside. So the next step, if you're interested in working on this, is there's this toolbox kit, a qualitative kit. So of how to conduct qualitative research for the index survey. So everything here, if you go back to the site, will take you directly to where you need to go. And at this point, I want to open it up for some questions. And then we have, oh, no, go right ahead. I'm sorry. I accidentally hit the slide.
I was just going to say, one question that I've had about the stigma index is, you have all this information from it. Do you have any insight on how you might measure stigma reduction out in communities? Like, we're starting to look at that here in Cincinnati and how we might be able to try to measure that and see like what activities we're doing, what advertisements, different things like that, that might lead to a reduction in stigma. But we don't really know how to kind of gauge that.
Mm-hmm. Well, ideally, although it's a long process, if you did the index survey in the same jurisdiction or same environment, say 1 year and then 3 years later, would you see a reduction when people took when those interviews and questions were done? Other than that, there are different tools and processes that people have taken to address stigma. There's the really good one is through NMAC, and they have 2 trainings called Escalate and Elevate that helps empower people and looks at further education around stigma and healthcare. There are also some different, approaches that individual jurisdictions have used and published as best practices. But it's one of those things that, we have to have a baseline before we can measure reduction. Because if we don't have a baseline, we can't tell how much better it's gotten.
Thank you. Right, that makes sense. Do you have any insight on, and this is kind of a similar question to what I just asked, but kind of when you're saying you do the stigma index in a jurisdiction 1 year, and then maybe you do it again 2 or 3 years later, that gives you the base and then shows you kind of what direction you're going in. Do you think there's any tool, or are there any tools out there that might allow you to measure something in a shorter period of time? Like, I'm thinking, say if somebody has a series of community events over the course of 3 months or something, and they want to kind of measure stigma in some way. Do you have any tips on how one might want to do that? And maybe that's not measuring the reduction, maybe that's measuring the baseline. But I just wonder how you think about how a community-based organization might go about doing this and integrate it into their own programming, maybe.
Oh, yeah, absolutely. And I love implementation science for this. Implementation science, thinking about how we get the gap from research to intervention faster, right? So that triangle I used was actually an implementation science framework. And what I would recommend to do with implementation science is small tests of change through PDSA cycles. So if you know that there's an area that scores high, can you implement an intervention using that plan, do, study, act cycle, right? Implement a short test of change, see what happens, evaluate, did it make a difference, keep it, toss it, try something new, right? And through that, and then you would use whatever your baseline tool was for assessment and use that same baseline tool again at the end to determine what that intervention has been. But implementation science provides a really good framework for using small tests of change to see if we're making a big difference.
Thank you for that. And we do have a question in the chat from Julie. The question is, are you familiar with the United Church of Christ intervention that uses the stigma index as a starting point for community conversations?
I am not. The faith-based community has done some really amazing things around HIV and HIV ministries and things like that, but I am not familiar with that. Actually, I'd like to learn more about it. So thank you for telling me.
Julie, if you've got a link or anything, maybe you could share that in the chat for us. Looks like it's called Framework for Dialogue.
I love it.
I'm just seeing, I think we've got another question in the chat. Hold on a second, everybody.
Oh, Coop, that's such an important point. Absolutely. We do treat it like it's okay. We really have stopped talking about it. We don't see a lot of new imagery about people living with HIV in popular media in a way that's healthy and sex positive. So yeah, in a lot of ways, we have stopped talking about it now that, we can live forever.
I have a question too. With the slide that you showed that had all the percentage of negative experience that people had with different aspects of the medical community, and then
Mm-hmm.
13% were people who were infectious disease doctors. Is that right?
And nurses.
And
So 13%, there were 13% of infectious disease nurses. Um,
that just really shows to me that we are really dropping the ball there. I wonder, when you look at this, where do you, because it seems like a lot to take in, that it's so many different aspects of the medical field. Well, how do you see like the best way of approaching to address that with that wide variety of people, like going from dental hygienists to infectious disease nurses? I mean, it's such a wide breadth.
I'm always a big fan of continuing education and people signing policies and non-discrimination statements. So when people are onboarded, they should be getting a HIV 101 and HIV 201 training, which most people aren't getting, I don't think, because we assume when people come into infectious disease, they have a background in infectious disease. And maybe they worked in tuberculosis or Hep C, which are very different than working in HIV. So making sure that people are getting that training, because infectious disease is a very broad field. OBGYNs, I'd actually like to see a movement from sort of the AMA or, an official organization for gynecologists and obstetricians to make a statement against HIV discrimination. That would be my goal. There would be a lot of work to be done with that. And when I think about dentists, I think, the dentists themselves probably don't get enough training. And it's really interesting to see that there's so much less that we find around office staff, because I know a lot of time we feel, we talk about maybe those people aren't providing individuals with the best first experience. But at least we see that, here people aren't seeing it as much. And it also makes me really happy to see that it doesn't seem to be discouraging people from going to the emergency department, that people are mostly having good experiences in emergency departments. But I think it's really education, training, and organizations making formal notices or having people sign non-discrimination statements.
Thank you for that. We've got another question in here from an audience member. That's how do you combat the new push away from DEI and in states like Ohio with a religious freedom exemption law? That's a very broad question.
That is a very big question. And if I solve it, hopefully I'd get nominated for the Nobel Peace Prize. But on a more practical level, I was at a continuing education event myself with someone who worked in harm reduction in West Virginia. And one of the things this person told me, if the only thing you can find in common with the person across the aisle is your shoes, start with your shoes. Right? So we have to continue to build cross-aisle collaboration, even when it seems the hardest, because we need to bring people on board, even if they don't necessarily understand, that they can accept that there's a reasonable level for intervention. Right? And thinking about states that have these laws, are there other areas for sex education or sexual health education outside of schools, right? Are there opportunities for doing that kind of work? Can we reframe the conversation so that we're looking at HIV from a public health position and not an interpersonal decision, right? And, when we think about where funding has changed and where funding cuts have been made, it's you know, unfortunately requiring us to do a lot of work outside the box. And, you know, my guess biggest and final statement, you know, would be vote. I know it seems hard, but, you know, down ballot races can actually be more significant and more important than up ballot, and thinking about what can change on a local level. Who's promoting sex safety these days, Denithia? I'm not really sure. TLC, no one. Well, you guys can go out there, promote it, be famous. Somebody send a tweet to Taylor Swift and tell her to get on that. Yeah, we need positive images in our community. Is there anything else that I can do for you guys today?
I think we might be good.
Little Nas. All right, I will
Well,
check
yeah.
out some Little Nas.
He's doing a little bit of that. Yep.
Yep. So here's some of the resources from your Midwestern AETC, as well as the resources that were used here. And like I said, if there's any articles you can't find or want a copy of, feel free to reach out. I'll be happy to share anything with the larger group.